Hey there, it's Dr. Cam, and welcome to Maximus Call-In Radio Show number 38. Great to have everyone with us. Shout out to our loyal community members on Discord. I see you, Ryan O. Hopefully you can ask a question sometime later in the show. For folks who are joining us on YouTube Live, feel free to type in your questions. We've had a good contingent of folks doing that. Welcome to everyone joining us on TikTok. Hey, Jen. And Instagram Live, and we also have audiences on Clubhouse. And I see Alan on there. Hey, Alan, and Twitter Spaces. So we are everywhere. Maximus is expanding aggressively. All right, so we start out with every week's show with a weekly unpopular opinion. And this week's unpopular opinion is that everyone knows that you can increase testosterone by improving your behaviors. But most people don't know that the best way to improve behaviors is actually to increase your testosterone. So let's talk a little bit about both of those strategies. So one of the things that we do at Maximus is there's a health coaching component to the protocol. And I wrote an 80-page ebook called Maximizing Your Testosterone that talks about behavioral strategies that are foundational to improving testosterone. So we talk about the right nutritional strategy or diet to optimize your testosterone. We talk about the right physical activity using strength training to increase your testosterone. We talk about getting sufficient and high quality sleep, 7 to 9 hours of sleep in order to optimize your testosterone. We also talk about focus, which is actually an underrated thing. Focus in and of itself doesn't modulate testosterone, but it's one of the key factors that indirectly affects all the other factors. Where the reason that most people don't get good sleep is because they're digitally distracted. They're on their phones, they're staying up late, they're doing their bedtime procrastination, which obviously interferes with sleep and thus testosterone. And then finally, we talk about the fifth health behavior, which is social accountability, which is how do you stick to all of these goals in terms of doing it on a consistent basis. And that obviously benefits from having someone who's cheering you on and providing social support and accountability. So we know that each of these health behaviors can improve testosterone. So for instance, we know, and we talk about sleep being a really particularly foundational health behavior, the difference between people who sleep 4, 5, 6, 7, and 8 hours a night, there's a clear linear association between sleep and testosterone. And it's about 10 to 15% increase with every hour of additional sleep that you get, up to about 8 hours. So what that means, of course, is the difference between someone who gets, let's say, 4 hours of sleep versus someone who gets 8 hours of sleep is approximately 50% difference in terms of their testosterone. So if you're obviously not sleeping very much, of course, fix your sleep as a core kind of foundational health behavior. So this is almost like common sense. People know this, but people don't realize that the opposite is also true, in that when you increase your testosterone pharmacologically, it can actually improve your health behaviors as well. And the reason for this is because one of the main benefits of having higher testosterone, because people always ask me, hey, Dr. Cam, okay, I get it, you guys increase testosterone, but what's the benefit? What's in it for me? And the answer to that, number one, is an increase in energy levels. And I always say that the key to productivity is not time management, it's actually energy management. And you manage your energy in two ways. By number one, getting sufficient recovery so that you're not burning out by doing things like sleeping, napping, taking breaks. But the other part of it is to make sure that you have the substrates or kind of the key elements that give you energy in the first place. And testosterone is one of those things. And so one of the things that's interesting that we find when you enhance testosterone pharmacologically through medications or pharmacologically through medications and supplements that are synergistic to it, although no supplements increase testosterone on their own, is that it increases your energy levels. And when your energy levels are higher, you can obviously go do those things. So a great example of this is physical activity, because it's the most energy requiring behavior out of all the 5 foundational health behaviors. Obviously, it takes a lot of energy to get up, go to the gym, and especially do heavy strength training. The number one reason, in fact, people talk about skipping or missing days at the gym is because we're all kind of chronically fatigued and tired, especially in this go-go sort of society. And so when you have higher levels of natural energy, we're not talking about caffeinated or stimulated energy, you're naturally more motivated to go to the gym and do the hard work of working out. Now, the interesting paradox, of course, with exercise is that in the short term, it depletes energy, right? Obviously, from the beginning to the end of the workout, you usually become more tired. But long term, of course, it's energy enhancing in that people who exercise consistently report higher levels of baseline energy. So, in order to have the energy that ironically exercise itself promotes through sort of a positive feedback cycle or snowball, you have to make sure that you have sufficient testosterone. And so, that's really the benefit of the pharmacological enhancement. And then the beauty of this, of course, the other thing I was going to say is that testosterone has a very interesting effect psychologically as well, in that it makes effort feel good. And that's why it's really unique and different than, I would say, stimulants, which obviously do increase your energy levels. Most people have experience with caffeine. But it doesn't, the motivational drive aspects, and this it could be a function of dopamine. We're not exactly sure. Testosterone and dopamine tend to go hand in hand. But the clear effect that we notice from having higher levels of testosterone is that it makes effort feel good. And so if you are facing a lot of challenges in life, you got some hard work ahead of you at work, in your personal life, having tough conversations, tough tasks, a lot of, tough responsibilities that you need to take on, it's very easy to shy away from them, to procrastinate, say, I'll do that tomorrow, or one day I'll finally chase my dreams, right? But when your testosterone levels are high, you're like, no, today is gonna be that day. I am gonna do the dirty work. I'm gonna clean it up. I'm gonna do it. I'm gonna put in the hard work. And so it makes that, but here's the interesting thing, it makes that easier and more enjoyable, right? When your testosterone is high, problems become challenges, is the way that I put them, right? As opposed to like, oh, it's this thing that I dread and I hate it and I'm gonna grit my teeth and bear it. Testosterone's like, nah, bring it on. Like if you think about like the archetype of a high testosterone male, maybe you've known some who are naturally high testosterone in life, right? They're positive people. They're optimists. They're like, yeah, bring it on. I like challenge. I like difficulty, right? I actually talked about in one of my previous podcasts, one of my classmates from grad school. And while everyone in the clinic, when we were getting assigned new patients, were like, I don't want the difficult patients because it's going to be challenging. I'm just a novice psychologist. I don't know how to treat these people. He was like, no, give me the hardest, the most difficult, the most complex, the most medically comorbid patients, because that's the only way I'm going to get better. And to his credit, he's a phenomenal psychologist. But I think it's because he had that high testosterone attitude, as I call it, right? In that he was like, I like challenge. It's enjoyable. Like that's how I test my grit or my mettle. And that's what testosterone gives you. It's almost infectious. Even when I talk about it, right? I get hyped up because I'm like, that's the beauty and the benefit of testosterone. So ironically, a lot of you may be listening to this and say, look, I know, Dr. Cam, I got to improve my sleep. I know I got to fix my diet. I know that, I got to focus more and spend less time on social media. So you know the things that you need to do, right? You know you need to get more sleep. It's like you don't need a doctor to tell you that, right? I think that's the thing by the way, I found hilarious about that book of Why We Sleep by Dr. Matthew Walker. No disrespect to him, but it's like, do you need a 200-page book to tell you that you need to sleep more and it's beneficial to your health? No, of course not. You need strategies to actually go and implement it. Almost everyone knows that you should get 8 hours of sleep. Okay, I say 7 to 9, just to give a little bit of a range. The question is how. The question is, what do you need to do to overcome the barriers to doing so? And a strategy that nobody talks about, in addition to obviously, hey, look, there's a lot of great behavioral strategies. I wrote, in fact, an entire article called The Keystone Habit that talks about how you spend 4 minutes at the beginning of every day planning the next 4 hours so that you can implement these behavioral strategies, right? So if you say, at 8 o'clock in the morning, okay, till noon, I'm going to get 3 hours of work done, right? And take some breaks in between. Great, that's an effective behavioral strategy, but it requires a lot of willpower to do so. So in addition to that, it's not that you should skip the behavioral strategies. You should also optimize your testosterone, because what you're going to naturally find when your testosterone is high at 8 a.m. and you're doing that keystone habit and say, all right, here's the plan. I'm going to put in 3 hours of work until noon. That natural energy to do so, that natural drive and motivation and looking forward to doing so, is just going to be so much easier when your testosterone is higher. So that's the beauty of it is, and this is why we combine medical pharmacological strategies with the psychological and behavioral strategies is that they're synergistic. When your testosterone's high, it makes doing the right behaviors easier. And when you do the right behaviors, your testosterone's higher. And it creates this positive feedback loop in both directions that not only makes your testosterone go even higher than either of those alone, so there's a synergistic effect, but it drives more and more behavior change in that it finally gives you the energy and the motivation to make the changes that you know you need to make, but now you finally have the means to do it. So that's why I'm a huge fan of multi-component treatments, meaning combining the medicine with the psychology, and it's just so much more effective. And that's why we do that combination through the Maximus King Protocol. So if you're interested in this, obviously check it out at maximustribe.com. I won't belabor it any further, but it's really an underestimated and underappreciated, I would say, point that not only do behaviors increase testosterone, but testosterone makes it much more easy to do the right thing and do the right behaviors. And people, when they realize that, they're like, oh, okay, now I get it. Now I understand why it's so beneficial to have optimal or high testosterone levels. All right. So let's get some live questions from the audience. It looks like we have one from YouTube. But before I get to that question, I wanted to see if anyone wanted to ask a live question from Discord or any other the other channels.
Hey Cam, how's it going?
Good. Hey Ryan, it's going well. How are you?
Doing well. Quick question for you.
Mm-hmm.
Do you have any actionable, like strategies, tips, or advice for somebody who may be struggling with erectile dysfunction or performance anxiety?
Yeah, and when you're talking about the second half of that, performance anxiety, you're talking about like performance in bed.
Yeah,
Okay.
totally.
Yeah. So no, it's a great
In
question.
terms of like some,
Go ahead.
yeah, just in terms of like some context, past two girls I've been with have kind of had this issue, and it kind of seems to be just more of a self-fulfilling cycle where it happens. I get embarrassed. I don't know what to do. So I was looking for any sort of strategy, advice that you would give.
Yeah. So let's try to understand the etiology of this. Like, what's the root cause of this? Is it literally only these last two women, or has this been a persistent problem before that?
I would say probably since college. It's been a minor issue. It'll happen sometimes, other times it won't. Last like long-term relationship, it's flared up towards the end, but that I think that was more because of just like extra life issues. And it seems to be kind of like whenever something happens like stressful in life, it comes up. Or on top of that also, if it's like the first couple times or if it's like with a new girl, I don't know. I just get it'll be like everything is fine and things are going well like during the hookup, but it's like when clothes come off, it's like it'll work sometimes, it won't work other times.
Yeah.
So it's kind of the backstory.
Yeah, well, first of all, thank you so much for sharing that. Like, I think, there's obviously an unfortunate, but I think unnecessary shame and stigma around erectile dysfunction. The reality is, like, it's very common. If you're talking about acute erectile dysfunction versus chronic erectile dysfunction, like, I don't think there's a single guy, quite frankly, that I know that in some sexual experience of their life has not had a problem with erectile dysfunction, especially if they've ever touched alcohol, which clearly contributes to that as well. That's why it's so useful to understand, like, as we're talking about, what's the root cause of it. Now, if I understood you correctly, it sounds like it's not been a persistent thing in terms of like the long stretches of time in which you could not, get an erection. It sounds like it's been more on and off. Is that correct?
I mean, besides the fact that it's happened since, like college.
Right.
It has been on and off too.
Yeah, so that's what I mean. It's been a long time since you've had it, but it kind of waxes and wanes, like even since college. Like, what I mean is, like, maybe you're okay one week, the next week it's not, or it's one girl it's okay, the next girl it's not. It's that kind of thing.
Yeah, that's right.
Yeah, so that's good news in my opinion, because from a case conceptualist conceptualization standpoint, you're trying to figure out, although it's very hard to separate mind and body, you do want to understand if there's more of a physiological root cause to your erectile dysfunction versus a more psychological cause. Now, like I said, these things are almost inextricably intertwined, but if you said, like, okay, I used to have no problem with my erections in my 20s, but I started to get older in my 30s and 40s, and I've just really lost my erectile function. And I've also gotten sicker, I've gained weight, I have diabetes now. I'd be like, oh, okay, well, it could be more physiological in origin in that as you're developing metabolic dysfunction, as you're aging, it may be, causing issues with your vasculature, which we know is like a side effect of diabetes. So interestingly, that's one of the things that, we've learned from actually our protocol. So like when guys are put on Clomid or enclomiphene, 75% of them actually improve, the research literature shows, their sexual function. About 25% of them don't get a response, but no medication is 100%, by the way. And that's because of the increase in luteinizing hormone, or LH, and free testosterone that happens basically in all patients. Now, what that suggests, though, is that, at least in those 75% of patients who respond, when you optimize their hormones, it fixes their sexual dysfunction, it fixes their ED. For the other 25% of patients, it's not that it doesn't work. It may be that the root cause of their issues, maybe it's more psychological, right? Or there's some other thing that's going on. It could be a third-party factor. And we know also from the research literature that basically as you get older, the responsiveness to Clomid and enclomiphene decreases. And it may be because, well, you get sicker with age, right? So as you develop diabetes, hypertension, coronary artery disease, multiple medication use, all of these are known risk factors for erectile dysfunction. So I'm assuming, well, you tell me, do you have any of those medical conditions?
Being transparent, I mean, I'm a bit overweight, to like currently to what I used to be.
Yeah.
Besides that, I mean, I haven't had a physical in probably since January 2020, and back then it was all signs are okay.
Yeah.
Nothing, off the charts. So I'd say on top of like the call it like excess weight,
Right.
Just also transparently, I've struggled with anxiety a lot of my life too. So that may be a extra cause as well.
Yeah.
But besides that, I don't think there's any kind of like outstanding like physical impairments.
Right. Yeah. And like you're how old-ish?
30.
Yeah. Okay. So you sound like a young guy. I can even just tell from your voice. So yeah, you're young, and other being then slightly overweight. You're not obese, correct?
I may be tipping towards that scale, but
What's your height and weight?
Months I've been. What's that?
What's your height and weight, approximately?
6'1" height of around 235 weight.
Calculator. All right, let's actually check out your BMI. Although BMI is kind of an imperfect measure, but it's not a bad proxy.
Yeah.
So 6'1", 235, you said? 31. You actually do slightly fall into the obese category. So has that always been the case? Like have you gained a lot of that weight recently, or since college you kind of always have been 235?
So kind of like a life trajectory. I was overweight until the end of high school. I think the heaviest back then was around, actually probably the same, 230-ish. And that was back when I didn't like go to the gym at all, eat terrible, just had a very unhealthy lifestyle. Once I got to college, I got down to about I think 83 was the lowest. And, unfortunately just kind of gained that back over the past few years.
Have you noticed a change or any relationship between your weight and ED? So for instance, like when you were in the 180s that you mentioned, was the ED better? Now that you've kind of gained weight in the last couple of years, has it gotten worse, or has it been pretty much the same?
I would say it's been generally the same. Just transparently, I would say looking back at a former weight, erection quality was better. back when I was 180, I'd say like 183 than it is now. But the issue doesn't seem to be, if I'm alone, and even sometimes like, if it's like, occasionally, I have no problem getting erections, but it just seems to be like, when things get going, get super nervous.
Yeah,
So.
makes sense. So the reason I'm kind of asking all these questions, like I said, we really want to understand if there's other confounding factors. It sounds like you're young, you're overall pretty healthy except for the excess weight issue, but you don't have a lot of the comorbidities that go with metabolic syndrome as far as we know. I mean, I would encourage you, by the way, you should go get an annual physical, as I recommend to every single person. I specifically recommend to guys too, make sure your doctor does a diabetes test, like in terms of checking your fasting plasma glucose or your A1C. Like you should know, especially because you're obese, you're at higher risk for diabetes, and almost everyone is at risk, unfortunately, for diabetes these days. I think like 37% of adult Americans have pre-diabetes. So everyone should just check their blood sugar. That's the standard recommendation. They'll do that as part of your annual physical if you ask them. Unfortunately, these days, unless you have hypertension, high blood pressure, they don't check as a standard. It's kind of crazy to me, given that like 1 in 3 Americans has pre-diabetes. But I think that's slowly changing. I would actually ask them to test your testosterone as well. I think it's a pretty reasonable ask, especially because you have some symptoms that, like I said, could be associated with hormone function, right? So just to make sure that it's not hormonal issue, just be like, yeah, I'm having some ED issues. Can I test my testosterone levels just to make sure that there's nothing going on sort of hormonally, right? Because as I mentioned, we do know that when we improve hormones, the ED 75% of the time goes away. So, but the good news is it doesn't sound like you have a lot of the other metabolic syndrome comorbidities as far as we know in terms of diabetes, hypertension, et cetera. You're relatively speaking for a healthy young man, relatively healthy. So it doesn't sound like there's potentially a lot of physiological basis for your ED. The only thing though is it's interesting to me that you said, okay, when I was weighing kind of in the 180 range, it seemed to be a little bit better. So obviously my advice there is like, and as we're working on in the coaching group, continue to do the great work that you're doing in terms of trying to lose the weight. Based on your past history, we know that the best predictor of future behavior is past behavior. I would guess or surmise that if you were able to get back down to that kind of younger weight in the 180s, you're going to feel better and your erectile quality will improve, right? We also know specifically that when you carry around excess body fat, especially around the middle and the stomach area, you have a lot of those aromatase enzymes. So a lot of your testosterone is basically being converted to estrogen because of the excess enzymes that you have because of your excess body fat. So the obviously this is a longer term kind of fix, but I do think that losing that excess body fat, that excess belly fat, is going to be foundational in terms of just making sure that there's nothing physiologically that's getting in the way of maintaining really good erections. Now, that being said, from what you're describing, especially the fact that since college to now, you are able to get, erections. It's just that sometimes it comes and goes. And there's two interesting things that you said, right? So the first is that you do notice that in times of like higher stress, it gets worse. And then two, when it's particularly with new women, there's a performance anxiety, which is another form of stress. It also gets worse. So given both of those things and very little, it sounds like, physiological basis, although verify that with your doctor and get a blood test, like I said, for testosterone, it sounds like if I had to guess, and I'm not doing a formal diagnosis here, I would put, 80% guesstimate that it's really more psychological in nature, in origin. That being the case, the solution is almost obvious, is you got to do some work to lower your stress and lower your performance anxiety in the situation. So let's talk about just sort of chronic stress management. So a lot of the things that we're doing in the coaching is going to just help you lower your baseline levels of cortisol, right? So first of all, fixing your sleep is going to be fundamental for that, because the less sleep that you get, the higher the cortisol. So for you especially, unfortunately, your sleep and thus your cortisol and stress levels, and thus it's going to impact your ED more than it will with other guys. So if that's any more motivation to fix your sleep and thus your cortisol levels, there it is. So I think that's going to be really helpful in terms of lowering your chronic stress or your baseline cortisol levels. There are some supplements that can kind of help with cortisol. A relatively safe one, again, not medical advice, consult with your PCP, is something called phosphatidylserine. It's a big fancy word, but if you can Google it, and I'll put a link in the Discord afterwards. Phosphatidylserine is a component of things like lecithin. You can actually get it from sunflower lecithin, and it's extracted from it. It's naturally occurring in plants, relatively safe, and it does seem to do a decent job at reducing cortisol. So there may be some anti-cortisol supplements. We already talked about sort of magnesium taurate as like a sleep supplement that I highly recommend. Both the magnesium and the taurine reduce anxiety. So there may be some supplements, again, with your PCP that may be helpful in terms of reducing chronic stress. That's going to be really helpful. And obviously, if there's other things that you find beneficial for chronic stress, I'm a huge fan of massage. I think it's completely underrated. I think if you have the money in particular to go do it on a regular basis, it is fantastic for lowering stress levels. And obviously other sort of alternative health practices, mindfulness, yoga, etc. Do whatever it's helpful for you to just lower your chronic sort of stress, because like I said, you're going to be more sensitive to it than other guys. Now, the other aspect of it, and this is honestly the most important of the three things that I talked about, is, okay, how do you reduce your performance anxiety when it's like a new partner, you don't really know them well, you don't know how it's going to go. And yeah, there is a lot of sort of anxiety that comes up, in those situations. So there are a couple things that you can do. And by the way, I think this is true for all guys. Like, it's really, really interesting how like sexual performance really differs so much when you're talking about a new versus an old partner. And I think a lot of it is honestly just like comfort and familiarity. When you have a long-term sexual partner, often in the confines of a monogamous relationship, like, first of all, you learn each other's preferences, right? You're like, I know what you like, you know what I like. I'm gonna do what you like. There's a whole Chris Rock skit, by the way, on this that's really funny that you should check out sometime. But when it's a new partner, you don't know, right? You're like, am I crossing boundaries? Is it strange if I engage in oral sex if they're not into it, or if I ask them to do it, do they think that's weird? So there's a lot of like hangups I think people have. So two things that I would recommend is, if that's what's driving the performance anxiety, is like discomfort around it, it's like better communication. And I know it's kind of strange when you're kind of hooking up with someone to like ask them, oh, like, what are you into? Or what are your preferences? Or do you like this or not like this? And it's the same thing, by the way. I always recommend people obviously ask about people's STI status. Like, hey, do you have anything that I need to know about? When was the last time you were tested? People don't do it because it's awkward. And it's a shame because, you're putting your own health at risk when you don't do that. But honestly, most people are never offended when you ask, whether it's about STIs, but also about what they're into. So I would say, like, good communication is the key to good sex. So first of all, like, make sure you do that. The second thing you can do in terms of like performance anxiety is slow down and take your time. I think with new partners, especially, there's a lot of excitement, right? That's understandable, right? It's like a new partner, you're excited about them. Guys generally get turned on more. This is the biological reality by new partners, and they tend to rush things. And I think as a result of that can lead to ED. And so what I would actually highly suggest in general, but especially in this situation, is more foreplay, right? Like, women know they need a lot of foreplay to warm up and obviously, have optimal sex, and especially if they want to achieve orgasm. Guys oftentimes don't even think about it because they're like, orgasm is almost a given for most guys. But I think in your particular case, especially because you have the performance anxiety, just slow down a little bit and just be like, all right, let's do some more foreplay, right? And that could, involve asking your partner to, start to stimulate you, whether it's by hand, orally, etc. So whatever does it for you, I think it can be quite helpful in terms of like, stimulating a good quality erection before you start to engage in intercourse, if that's obviously the kind of sexual activity that you engage in. So I think that's going to be really helpful. And then one final question for you is there a thought, is there a cognition that's driving the performance anxiety? Like, do you think, okay, I'm just going to speculate, say something like, oh, I'm going to be really embarrassed if I'm not hard, or I'm, worried that I'm going to come too fast, or is there a specific worry that's driving it?
Yeah, so I've had two consistent worries that I think come up in the back of my mind.
Mm-hmm.
I'd say like in maybe like younger years, it was actually about like finishing too early,
Mm-hmm.
and the control behind that too.
Right.
But the past couple of times it has happened, it's been, um, sorry to get graphic, but like,
No, that's fine.
it'll be, during like oral sex, I'll be fine, and then when we move on to go,
Mm-hmm.
to vaginal intercourse, I'll like this thing will pop up in my mind. It's like you're not going to be able to get hard,
Mm-hmm.
and it almost becomes like this self-fulfilling prophecy.
Mm.
Like I almost don't know how to turn off that voice. And
How
like when it's happening.
right?
What's that?
How often does that actually happen though? Like if you look at just like I don't know the last 10 times you've had sex, how frequent of an issue is it?
I'd say probably three,
Okay, so
three, four
I
out of
think
10.
that's the important thing to tell yourself, right? If you're creating a self-fulfilling prophecy for yourself, what's happening is you're having a negative thought. The negative thought is, I'm going to have ED. That probably increases your anxiety, and then you're more likely to have ED, right? But if we're actually going to be super rational about this, right? This is like the foundation of cognitive therapy, is you're making a negative prediction. But when we actually go back and look at the evidence for it, you're saying, well, 70% of the time, I'm just fine. Now, it does happen 30% of the time, but more often than not, I'm fine. So I think it's actually really important in the moment because you know that your thoughts are driving your feelings, which is driving your behaviors, or in this case, your erection quality. It's important to say, hey, look, yeah, it happens from time to time. And maybe I don't know about this time, but more often than not, at least 70% of the time, it's going to be okay. And I think when you do that, your physiology calms down. And you're like, oh, okay, like it's probably going to be fine, right? So I think that's really important to tell yourself is just don't freak out and just be like, have a, really, really negative prediction and say, I'm going to have ED because, like you said, it becomes a self-fulfilling prophecy. Say, look, actually, I don't know what's going to happen, but most of the time I'm fine. Let's just see how it goes. And then your anxiety will sort of subside. The second question for you is, of course, now 30% of the time, it does happen, right? So worst case scenario. How do you handle it in those situations? And is there anything that helps? Like, is it a total like disaster, or do you kind of find a way through it?
The past two times, honestly, total disaster. Most of that is on my end too.
Mm-hmm.
It'll either be like, oh hey, sorry. Honestly, it's incredibly embarrassing. So the past two times it's happened,
Mm-hmm.
one time I just kind of left afterwards.
Yeah.
And then the time before was like with more of a girl that I was seeing a bit more
Yeah.
regularly, and like we just never talked about it. And I think that's the actual issue is that it happened. I almost things were going well out on a date, getting fired up,
Sure.
get back to her place, and then it happened, and I just never really actually talked about it. I kind of just like, and I think, and because of that, I was scared that it was going to happen again. So
Right.
eventually things kind of just fizzled out.
Mm-hmm.
And I get that is likely a communication issue on my end. So
Yeah, I mean, it makes sense. Like, I feel your pain, like, when I hear your story, because in the sense of, like, yeah, sure, like, who doesn't get slightly embarrassed by, not being able to perform? Although, like I said, it happens to all of us, happens to the best of us. So let me just continue to normalize that. But here's the thing. You're making it actually worse than it is, right? So if we go back to this premise of saying, like, look, it happens to everyone. Like I said, I don't know a single guy it doesn't happen to occasionally. Now, it's really how you deal with it that matters. So my question is, there's something called decatastrophizing in CBT, which is like assuming the worst case scenario happens, which in this case it's like, okay, sure, you get ED 30% of the time, so be it. How can you cope with it, right? So it sounds like the last two times you didn't cope with it really great because you either kind of took off or you didn't kind of talk about it. You kind of, you're embarrassed about it. That's why it makes sense. And you kind of swept it under the rug until things fizzled out. But let's just say it does happen. And you obviously you're not in the moment. You're stepping back and having this conversation with me. What would be like a mature, healthy, confident way of dealing with it? Like how could you handle it the next time it happens?
I would just tell her that, hey, sometimes get a little bit anxious first couple times. I would also probably say something along the lines of like, it's not you. It's not an issue about like I'm clearly attracted to you, and let's keep doing like whatever you're comfortable doing, and see if it works later.
Yeah, absolutely.
Kind of making it less of, I wouldn't say an issue, but just putting the pressure off and actually like even acknowledging it. I think even now like is making me like feel like that like actually just feels better. Like, talking about it, acknowledging it, and then either just waiting. If it doesn't happen, it doesn't happen, or going and just kind of I think talking about it, just bringing it up. Actually would be quite helpful.
I think you hit the nail on the head too in terms of taking the pressure off. Those are the magic words. You got to take the pressure off yourself, and the way that you take it.
Almost like, what's the best way? Almost like saying like, hey, if it doesn't work, or if it doesn't work, it's okay. And then just kind of keep whether like going with whatever she wants to do or just like, yeah.
Let me ask you a question. Do you have issues with ED if you're having oral sex, or is it just vaginal?
Just vaginal.
So there you go. You have a solution, right? Which is like, look, like what's the backup plan? What's plan B? It's like, look, if it's not working, having vaginal sex, just be like, hey, all right, let's just do oral this time around. And you have a solution. You can obviously get pleasure from that. I think sometimes it's even better, depending on how good your partner is. And same thing with her, by the way. There's a lot of women who enjoy oral sex more than vaginal sex, especially obviously if it results in orgasm, which is much more likely to, especially if you know what you're doing. So yeah, the thing is, you can enjoy sex if you're using the broad umbrella of what sex is in terms of pleasuring yourself and your partner without needing to do vaginal intercourse. But here's the trick of the whole thing. The moment that you take the pressure off and say, I don't need to absolutely perform using only vaginal intercourse and otherwise it's a disaster. If that's your expectation, then you're creating pressure and it's leading to ED. Versus if you say, hey, you know what? I would like to have vaginal intercourse. That'd be great. But it's most likely to happen 70% of the time. In the 30% of the time that it's not likely to happen, then I'll take the pressure off and we'll just have oral sex and it'll be fine. Or we'll wait. That's plan C, as you put it. Like we can just chill out. We can have a couple laughs. We can just cuddle, have the more emotional intimacy aspects of it, and then try again in a little while. There you go. You have plan C. So I think going through these are kind of, this is why I said it's decatastrophizing. Going through the coping steps of, okay, even in the unlikely worst case scenario that the thing I don't want to happen, ED, happens, I can deal with it. It's not a huge deal. It's not my preferred thing, of course, but it's not a disaster. It's not a catastrophe. It's not the end of the world. And the moment you do that, ironically, your anxiety goes down. You're going to be able to get hard. And I bet you'll even go from 70 to 90% of the time, you'll be able to maintain your erection quality because psychogenic meaning it's psychological in origin. This is mostly driven by your performance anxiety. So the clear solution to performance anxiety is to just reduce the pressure, as we put it. And I think that's the good point. So yes, the talking through it is effective. But what about the talking through it? It's effective. It's not even necessarily that you need to communicate it, by the way, to your partner. I don't think you need to, by the way, apologize for having ED. It's not your fault. You can apologize for being a selfish jerk in bed, like apologize for that, but you don't have control over your dick, as most people don't. So you don't need to apologize. Be confident in bed is the way that I'd put it. But you may want to talk. You could talk about it. You'd be like, hey, like right now, I think it'd be better for us to just have oral sex. But she'll get it. You know what I mean? So yeah, you don't need to necessarily. It's not that it's the communication with your partner that's the problem. It's honestly the communication with yourself, in that you're creating this internal pressure that she may not even like feel. She's like, great, we have oral sex, like, fine by me. You know what I mean? So if you just change the way that you communicate with yourself in a way that's like less pressured, less anxiety producing, and less causing of a negative downward spiral, um, two things will happen. Like I said, your erections will probably get better, and this will be less of a problem. Or two, even if it doesn't get better, it's not a big deal to you because you can still have fun in other ways.
Agreed.
Yeah. So I mean, I think I'm actually quite optimistic for you in the sense that, um, like I said, it sounds more psychological than physiological, and as a result of that, just doing a little bit of this cognitive work in terms of um, realizing that the odds of the bad thing happening are not as bad as you initially think they are, like I said, 70-30, and decatastrophizing, like just going through the coping motions of like, yeah, there's plan B, there's plan C, there's other things we can do. It's not a big deal. Let me take the pressure off. It's going to help tremendously. Now, one final thing. There are obviously medications and supplements that you can take that specifically help ED. Now, an over-the-counter supplement that work really well is something called L-citrulline. It's a naturally occurring amino acid. Taking about 5 to 9 grams of L-citrulline before you engage in sexual activity. Ideally, take it a couple hours before, or maybe like, let's say, an hour before, let's say. People actually ironically use it as a pre-workout. It's a vasodilator. It expands your blood vessels, which will not only give you a great pump in the gym, but better erections in bed. So it actually does work, and there's good scientific literature that you can look up that shows, even in some instances, comparable efficacy to prescription PDE5 inhibitors, such as Viagra and Cialis. So obviously consult with your doctor, make sure it's okay to take that, but it is a common over-the-counter supplement, and it does work really well. So if you know you're having sex and you have the time and the means to take it beforehand, taking it does seem to help. 5 to 9 grams is a high dose, so it's better to buy it in powder form. You can buy it in capsules, but like taking 1 gram capsules, you have to take like 5 of them. So you figure out what works for you, like logistically. The alternative, of course, is you can actually, and which is much stronger than L-citrulline, is to take a PDE5 inhibitor. You can obviously go talk to a doctor and consult if that's right for you, and you're safe to do so. You don't have high blood pressure or other issues that would contraindicate it. But Viagra you can take in the moment, right? So if you know you're having sex, like 30 minutes before approximately, you can take it. I personally am not a huge fan of Viagra because I do think it has some side effects. Like headaches are very common in people who take Viagra. The alternative is to take Cialis, or the generic name is Tadalafil. The difference between Viagra and Cialis is Viagra has a short half-life. You take it basically like right before sexual activity. Tadalafil you take and it lasts for like 2-3 days. And the benefit of that is a lot of people just take it before the start of the weekend when they know they're having sex, and they don't have to sit there and try to time it like, oh, it's 30 minutes. Am I leaving the restaurant? Are we going back to my place? You don't have to stress about that. You just take it and you're good to go. A lot of people, in fact, take low doses of it, 5 milligrams approximately, every single day. And they're just ready to go, and it just improves your erection quality. It also has some really great other benefits, which is, like I said, it's a vasodilator, increases your pump at the gym. It increases muscle protein synthesis, so it helps you gain muscle if you lift weights. And it has some cardiovascular benefits in that people who take Tadalafil have lower instances of cardiovascular disease, and so it's really an anti-aging medication. And so if it's a chronic problem and the psychological stuff does not help, which I'm actually very optimistic that it will, you can always use erectile dysfunction medications, and it will help in terms of, vasodilating it. But I think in your particular case, given everything that we've talked about, your problem is really more psychological in origin, which is good. You want it to be psychological in origin, because if you're thinking yourself into the problem, then you can absolutely think your way out of it, right? And that's exactly what we're doing that's the basis of talk therapy. I'm just kind of mentioning the pharmacological stuff because for two reasons. Is like, one, just in case it doesn't work, then you have a backup in terms of treatment options. But also, interestingly, I think some of the benefits of the PDE5 inhibitors like Cialis are ironically more psychological than physiological, in the sense that if you're taking something that you know kind of gives you erections, then you chill out about it, right? And then you're like, oh, okay, like I have something that's like physiologically going to help. And so ironically, your anxiety about it goes down. And then it eliminates your performance anxiety. Not that it's an anti-anxiety medication, but it's almost like a safeguard, if you will, right? And if you take it, you're just like, oh, okay, my erections are probably going to be good. I don't even need to worry about this issue anymore. So ironically, it's like a safety signal, like if you will, in a beneficial way. So my recommendation, though, and I tell this is regardless of you, I tell this to everyone who deals with sort of these things. Always try the psychological and behavioral route first, right? Always try therapy first if you're dealing with a mild to moderate issue. If it does not help and you've given it the good old college try, then of course you can take medications as well. But really try to address it first. Like I said, like lose the weight long term, obviously. Make sure you're getting enough sleep so that you don't have excess cortisol. And then, do the kind of cognitive kind of restructuring that we've talked about in terms of like, this is a low likelihood event and I can cope with it even if it does happen. And like I said, 80% of the time that will fix it. Sure, if you still have some residual issues, you can look into some supplements and medications as well.
Totally. And one last point that I think rings really true, and I almost didn't even realize until you brought it up, is the fact that I'm kind of taking myself out of the running before I'm even up
Totally.
at bat. It's like I've had this happen in the past, sure, but the cycle that I'll get into is it's always going to happen in the future, and because of that, I'll like spiral downwards. I can see now how like using those CBT techniques is likely helpful to kind of put myself in front of my thoughts, chill out a bit, not catastrophize, and yeah, I'm gonna try that next time and not be afraid to keep going on dates and keep at it.
Yeah, absolutely. Because that's a great point, right? Not only are you creating a negative self-fulfilling prophecy in the moment, right? Because you're like, oh, I'm worried about having ED while I'm having sex. But if you're having this long-term thought too, like this is always going to be a problem, then that perpetuates it as well. But if you listen to kind of what I said, right? I'm kind of like doing this like case conceptualization on the fly with you, and I'm like, based on what you said, I'm really optimistic that this is going to get better for you, right? Because like I said, now if you were like, I'm 80 and I have diabetes and hypertension and I can't feel my toes because the neuropathy has gotten so bad and you've probably ruined your vasculature, I'd be like, this is not going to go away by changing the way you're thinking about it. You should probably take the medication in consultation with your doctor, of course. But what you're describing, because it's so psychological, I'm like, yeah, this will totally get better because you can think your way out of it. So as a result of that, that's the last thing you should think to yourself is the opposite. You're like, this is not going to be a problem long term because now I've talked through it with Dr. Cam. I have a couple of great coping strategies that I can use, and I'm gonna chill out about it, and I can control my performance anxiety because I can reduce my own pressure. And so when you think that to yourself and you're like, this is going to get better, your optimism gets better, your anxiety gets lower, and it will get better.
Totally.
Awesome.
Thanks, Cam.
Thank you so much for bringing it up. And thank you so much for talking about it. Like, I know this is an issue for everyone, and like, not everyone has the courage to talk about it. And I'm glad that you did, because I guarantee you for every person like you who's willing to talk about it, there's like 10 other people who are listening and they're dealing with the same thing. So thank you for destigmatizing that a little bit. Obviously, let us know in the future if you want how it goes and how it's improved. Like I said, I'd be willing to put my money that it's going to get better. And obviously, I'd hope to hear you say that as well. So thank you for bringing that up. Let's jump up to other questions from the audience. I think there was one from YouTube you want to ask, Victor?
Yeah, we had a question from YouTube. Can you explain how enclomiphene works? Google seems to say it's an estrogen receptor antagonist, but I heard you mention it stimulates testosterone production. Which is it mainly?
Yeah, great question. So the question is, like, how does enclomiphene work? And it sounds like the person who's asking the question is a little confused. They're like, is it an estrogen receptor antagonist? Does it stimulate testosterone? Well, the answer is it's both, and that's exactly actually how it works. So the mechanism of action is that it is a estrogen receptor antagonist, which, as we've talked about before, you have these estrogen receptors. They're like locks and keys, right? The receptor agonist is like a key, and then the receptor is the lock, and the key unlocks the lock, and so that's how it kind of works. But what a receptor antagonist does is it's almost like a bad key. It goes into the lock, but it doesn't unlock the door because it's not really meant for that lock. And so what it does is it blocks estrogen from binding to the receptor. And so it kind of floats around in your blood, but it's not able to like do its magic, so to speak, in terms of how it works. Now, what that does is the body thinks that it's not getting enough estrogen because it's being blocked, and it's actually not in terms of the mechanism of the estrogen receptor. And so it'll stimulate the testes or your testicles to produce more luteinizing hormone and thus testosterone. So that's actually the mechanism of action of how it works. So it's both. We had a related question from the previous week that I'll answer since we're talking about enclomiphene. So for those of you who don't know, enclomiphene is one of the medications that your doctor can choose to use as part of the Maximus King Protocol, but it's the one that we mostly use. So the question was, is the research that's been done on enclomiphene mostly on guys with low testosterone? Have the effects on guys that already have high testosterone been researched? What a great question. So I actually looked into the research literature on this just to answer this question for you. And I think Victor has a diagram that he can actually pull up. And I can talk about this research study. So most of the research, of course, that's been done on enclomiphene or Clomid is in guys who have low testosterone, because why else would you do the research, right? So these are guys who typically have secondary hypogonadism. So that's right. Most of the research studies are in guys who have low testosterone. However, there is a group of guys that they've done it on. If you remember, Clomid is originally a fertility drug. And so now, while infertility and low testosterone are correlated, there are lots of guys actually who have low testosterone, have no problems with fertility. And conversely, there are guys who have infertility, but they don't have a problem with testosterone. So this study, in fact, that we're showing the diagram this way, was in 18 men who had some infertility issues. And it was giving them Clomid, which is kind of the parent drug of enclomiphene, and looking at the effects not only on improving their fertility, but on testosterone. And what they found was it increased their testosterone. You can see in this top diagram right here, pretty significantly. So it went from 9 to 20 nanomolars per liter. If you convert the units, that's basically going from a testosterone of 260 nanograms per deciliter to 577 nanograms per deciliter. So it's a pretty significant improvement in testosterone. And so we know, obviously, Clomid works pretty well. It over doubled their testosterone levels. Same thing that we found in our studies with enclomiphene. But here's the interesting part. If you look at this lower chart right here, it actually plotted every single one of the trajectory of those 18 men. So what's interesting that you'll note is that if you look at where they start, which is the baseline, like right here, there are some guys that are hypogonadal, meaning they're low testosterone. So these are the guys that are below, on this chart, 9 or about 260 in terms of their total testosterone. What's interesting, though, there are guys that are not hypogonadal. Now, they're not high testosterone, but there are some guys here, if you look at the top of the chart, right across there, who are about a 12. And a 12 kind of corresponds, in terms of nanomolars per liter, to about a 346 nanograms per deciliter. So it's lower testosterone, but it's not low enough to actually be clinically hypogonadal. And you can see from the chart that those guys, every single guy, all 18 of them, significantly improved their testosterone levels. So what that shows is whether or not you have low testosterone or even low normal testosterone or normal testosterone, Clomid works, and it increases it in literally every single one of those guys. So it works super well. And then if you bring up the other chart, now we have our own data because we've looked at guys who are even healthier and more normal. And so if you look at this chart, it actually has what's called a box and whisker plot. A box and whisker plot is basically characterizes a range. And so you can look at the people in our study over there, and that blue kind of overlay on that chart basically shows what the normal levels of testosterone, free testosterone are. So in our lab, the normal level of testosterone, free testosterone, is between 44 and 144. So you can see up there. Now you can see most of the guys actually in our study, if the box and Worcester plot, the purple box designates between the 25th and 75th percentile. So ironically, most of the guys in our population actually were in the normal range for free testosterone. Now the whiskers, which you can see over here, there are some guys who are below normal, and there are some guys who are even a little bit higher, right? So I would say it looks like about 80% of guys were in the normal range, maybe somewhere below 20% of guys were in the subnormal range, or they're kind of have low testosterone. Now you may ask yourself, well, why are these guys doing the protocol if they're not low testosterone? Well, because we treat symptoms, not numbers. So these guys, even though they're not clinically hypogonadal down here, they are on the lower range, right? If the range is between 44 and 148, they're not optimal, right? They're kind of low normal, if you will, and they have room for improvement. And as a result of that, they're feeling symptoms, low energy, low libido, maybe excess body fat that they wanted to improve. Now, what happened, obviously going on the protocol, you see a pretty significant increase over there, increase of 2x of testosterone. So we also know from our own this clinical trial that we ran that even in guys who have higher levels of testosterone, these are clearly guys that are, some of them in the low normal range, but there's even guys that are like started out pretty much average, I would say, right? They're right around 100. So what happens to those guys that are average in their testosterone? They go from average to high, right? So oftentimes they'll go from 100 to like 200 in terms of their testosterone levels. And even though that technically is above the reference range in the study, as I mentioned, is between 44 and 148. What we find, though, is 200, as we talked about in a previous show, is actually quite normal. It's not super physiological if you're talking about healthy, young, non-obese men, right? In fact, for healthy, young, non-obese men between the ages of 19 and 39, a level that's like 220, 230, according to Dr. Ship, and even 250 would still be considered normal. So all we're doing is putting guys up into the high normal, optimal range that a healthy young athlete would actually have. So the moral of the story, basically, to answer your question, is yes, there's scientific literature that shows that Clomid has been used in guys that do not have low testosterone hypogonadism. It still works for them. We've also found in our clinical literature that with guys that are either low normal, normal, or even sometimes a little bit higher, it still works for them. It's just such a consistent effect of the drug in that it works really well. So, and as I mentioned, guys that are younger and have less chronic diseases, they respond even better, not just in terms of the increase in testosterone, but in terms of the symptomatic relief, right? So it improves the ED more, improves your sex drive, improves your libido even more if you're healthier. So ironically, I would actually argue that it works even better in healthy young men. And the other thing that's interesting that we found in our studies versus the clinical trials is we need to use less of the dosage. We use a minimal effective dose. Oftentimes we found that, for instance, 6.25 milligrams of enclomiphene, which is half to a fourth of the dose that's used in the clinical trials, is enough to double people's levels. And that's something that we discovered, right? And so that's a really interesting finding, and that's showing that if you are younger, healthier, or maybe your testosterone levels are higher to begin with, you just don't need as much medication, right? And so I would actually argue in a healthier population, it works even better. And you're even a better candidate for it in terms of you don't need that much to get a testosterone boost. It still works consistently even if you have high testosterone. And if you do have some symptoms in terms of like maybe low libido or sexual drive, you're gonna be much more likely to be responsive. So all in all, I actually highly recommend it. It's even has a better prognosis or higher likelihood of better outcomes if your testosterone is not super low. Because there are some guys that are going to be super low in testosterone, like below the 2.5 percentile, who may need to be on testosterone replacement therapy. But that's not the bulk of people that we see. Like I said, that doesn't apply to 97.5% of people.
We had a question from YouTube. Is there a risk of increased estrogen sensitivity from taking or after stopping enclomiphene? Do you have to take it indefinitely?
Yeah, I'm not sure what an increased estrogen sensitivity exactly is referring to. I mean, if you think about it, it's an estrogen receptor antagonist, right? So it's blocking the effect of estrogen it's not making you more sensitive perhaps to it. It's blocking from the ability of estrogen to bind to the receptors. So as a result of that, it's not having that effect. And then second of all, remember that enclomiphene excludes the zoochlomiphene isomer, which is an estrogen receptor agonist. And because it's more pure than Clomid, it has less estrogenic qualities, and it has less estrogenic side effects like the mood and lability sort of issues that you see sometimes in Clomid sort of patients. So now the second half of your question is much more clear. Do you have to take it indefinitely? Do you have to do anything in life indefinitely? No. There's no, let me put it this way. It'll double your testosterone levels as long as you take it. There's no medication, by the way, that like you take it and you stop taking it and it keeps lasting forever. It's kind of if you understand how pharmacology works, it's kind of a silly question, to be honest with you. The only things that I know that really do that are like, if you have an infection and you take an antibiotic, it'll clear the infection. Obviously, you don't need to take it forever. Or if you take a vaccine, at least for a very long period of time, 6 to 12 months, at least with COVID vaccines, it has an enduring effect. But if you think about any other medication, like let's say a blood pressure reducing medication, as long as you take it, it'll reduce your blood pressure. And what happens if you stop taking it? It'll go right back to where it was. Same thing with enclomiphene or any other testosterone improving medication is it will increase your testosterone as long as you take it. And when you stop, it'll go right back to where you were before. Unlike TRT, which will not just put you back to where you were before, it'll actually plummet it and suppress it down to sub-physiological ranges. So the thing is, if it's working, why would you stop taking it? It just becomes part of your normal life. There's lots of people, for instance, who take a little baby aspirin, 325 milligrams, because there's been large studies that show that it reduces the risk of having a heart attack. And it just becomes part of your daily life. Enclomiphene, for most people, is relatively safe, obviously in consultation with your physician. And so you don't have to discontinue it because there's not long-term negative side effects. In fact, in the clinical trials, the side effects were no different than placebo. So as long as it's continuing to benefit you, like you're getting the cost benefit outweighs it, you can take it indefinitely. And there's long-term studies, at least with Clomid, that have shown that at least for 3 years out, that people can take it without any long-term side effects and any adverse events that require them to drop out. So for most people, they'll be on it long-term as long as they want to continue to have the benefits of high testosterone and all the other sequelae that come along with that in terms of the better energy, better mood, better libido, better sex drive, better body composition in terms of more muscle and less fat. Guys, thank you for a great call-in radio show number 38. Really appreciate the live call-in question about how do you deal with ED, understanding sort of the physiological versus psychological reasons for ED, and how you can actually address some of the psychological reasons using cognitive therapy and sort of using cognitive restructuring to reduce performance anxiety. And I also talked about some supplements and medications that may also help as well if there is a little bit of a physiological basis to it. We also talked about how enclomiphene works, one of the core parts of the Maximus Protocol, in terms of how it works equally as well for not just guys with low testosterone, but it works even if you have normal to high testosterone. And in fact, it works even better in terms of needing less medication to get as much of an effect, and also having greater symptomatic relief with things like erectile dysfunction, and also how you can pretty much take it safely for long term as long as the cost benefit is worth it for you. So really great questions. If you have any more, please submit it to us through our social media channels, and we'll catch you next week, Thursday at same time, 6 p.m. Thank you, everyone.